And my dear students, I welcome you all to seventh session of theory questions and answers discussion. Today, I request Dr. Muthupriya to start again with ARDS. Over to Professor and students, please.
Yeah, you can go ahead. Yeah.
Yes, sir. Good evening, everyone. Today, I'm going to present about acute respiratory distress syndrome. It's a syndrome of hypoxemic respiratory failure associated with non-cardiogenic pulmonary edema. It is associated with multi-organ dysfunction and carries high mortality. ARDS definition according to Berlin's criteria, it is acute diffuse inflammatory lung injury, which leads to increased pulmonary vascular permeability, increase in lung weight, and loss of aerated lung tissue, which later leads to hypoxemia and bilateral radiological opacities. There is increase in physiological dead space and decrease in lung compliance. The four diagnostic criteria for ARDS are: it is acute in onset within 7 days of defined trigger or clinical insert with new or worsening symptoms, bilateral lung infiltrates on the chest X-ray or computed topography, edema which is not fully explained by cardiac failure or fluid overload, and degree of hypoxemia with PaO to FaO2 ratio less than 300 mm of mercury with a PEEP of 5 cm of water. Based on the PaO2 and FaO2 ratio, we are classifying this ARDS into mild, moderate, and severe. In mild ARDS, the PF is about 200 to 300 mm mercury with ICU mortality of about 30%. In moderate ARDS, PF about 100 to 200 with ICU mortality about 35%. In severe ARDS, the PF ratio is about less than 100 with ICU mortality about 43%. So coming to the causes of ARDS, it can be of pulmonary and extrapulmonary causes. The pulmonary causes are pneumonia, aspiration of gastric contents, pulmonary contusions, inhalational injuries, pulmonary vasculitis, and near drowning. The extrapulmonary causes are sepsis, non-cardiogenic shock, multiple trauma, massive transfusion, burns, drugs, and toxins. Coming to pathogenesis of ARDS, it is of three phases: acute inflammatory phase, proliferative phase, and fibrotic phase. In acute inflammatory response, there is an alveolar capillary damage. This is due to the release of cytokines like tumor necrosis factor alpha, interleukin 1, 6, and 8. This leads to the neutrophil migration to the alveoli and release of reactive oxygen species, which give rise to free radical production. This causes the endothelial and the type 1 pneumocyte damage, which can lead to alveolar and capillary endothelial damage ultimately. This leads to the accumulation of exudates, that is the protein rich in alveoli in the interstitium, leading to non-cardiogenic pulmonary edema. And the plasma proteins in the alveoli denature the alveolar surfactant, causing alveolar collapse and ultimately causing shunting, which later leads to hypoxemia. In phase 2, we have the proliferative phase, which is seen in 72 hours to 7 days. There is proliferation of type 2 pneumocytes and fibroblasts and myofibroblasts, which can later lead to third phase, that is the fibrotic phase, or in resolution. The fibrotic phase is the end stage process of the disease. And coming to the management, the goals of ARDS is to decrease the shunt fraction, increase the oxygen delivery, decrease the oxygen consumption, and avoid further damage. So the goals of ventilation in ARDS is, according to ARDS network protocol, you should have an oxygenation about like PaO2 of about 55 to 80 or SpO2 about 88 to 95, and tidal volume about 4 to 6 ml per kg, plat tube pressure about less than 30 centimeter of water, pH of about 7.35 to 7.45, respiratory rate less than 35. So the main aim is to avoid exaggerating lung injury and provide support to care in ARDS. It can be classified into ventilator strategies and non-ventilator strategies. In ventilator strategies, we have the lung protective ventilation. The principles are: we have a low tidal volume with controlled pressure, appropriate use of PEEP, rationalized FiO2, and permissive approach to hypercapnia. In permissive approach to hypercapnia, means in ARDS, we have a small baby lung, that is a lung which is aerated tissue not affected. We should provide a low tidal volume so that it doesn't get over distended and cause barotrauma, so that we allow a permissive hypercapnia till the pH is about 7.2. In low tidal volume ventilation, it is done to prevent barotrauma and alveolar overdistension. We give a tidal volume of about 4 to 6 ml per kg based on the ideal body weight, plateau pressure less than 30, pH about 7.35, and respiratory rate less than 35. In PEEP, we prevent the alveolar de-recruitment, that is, we decrease the atelectasis, increases FRC, and displace the fluid from the alveoli to the interstitium, which resulting increased compliance. Prone position ventilation, it increases oxygenation by improved recruitment of the atelectic dependent lung zones, which improves the lung compliance and EVQ mismatch. It decreases alveolar hyperinflation and decreases the cardiac compression of the underlying lung, which further improves compliance and VQ mismatch. Prone ventilation should be used at least a minimum of 8 hours. It can be used in moderate to severe ARDS for about 12 to 16 hours per day. In airway pressure release ventilation, we increase the inspiratory ratio up for about 2:1 or 3:1 to increase the oxygenation. High frequency jet auxiliary ventilation, it is usually done in pediatrics. Here the lung is held open at an increased mean airway pressure about 25 to 30 centimeter of water with a small tidal volume about 1 to 3 ml per kg at a frequency about 3 to 15 hertz, respiratory rate more than 35 per minute. But it is not much in use for ARDS and it is associated with increased mortality. Recruitment maneuvers are done to open up the collapsed alveoli, that is transients rise in the ventilated pressure to open up the collapsed alveoli, reversing atelectasis and increasing the lung area for gaseous exchange. We can do it as a sustained inflation or a stepwise increment in PEEP or in sustained inflation. We give a CPAP pressure about 30 to 40 centimeter of water for about 30 to 40 seconds to open up the alveoli. But disadvantage as it causes hemodynamic instability and barotrauma due to recruitment. ECMO, it's the last rescue therapy for severe ARDS or refractory hypoxemia. We use veno-venous mode. Other adjuvants used in ARDS are inhaled nitric oxide, prostacyclins, beta-2 agonists, statins, and ketoconazole, but they are not. There is no much benefit suggested. And coming to the non-ventilative strategies, we use conservative fluid therapy. As increased fluid overload can lead to pulmonary edema and decreased fluid therapy can lead to AKA. So we should use conservative fluid as it is associated with decrease in ventilator-free or ICU-free states. And neuromuscular blocker is given to improve patient ventilator synchrony, and it is improve the oxygenation and compliance. It eliminates coughing and decreases barotrauma. Steroids like methylprednisolone can be given as 1 mg per kg per day in moderate to severe ARDS, but the side effect is it is associated with hospital-acquired infection, neuropathy, and delirium. And risk factors, risk of ventilation in ARDS, it is associated with ventilator-induced lung injury and oxygen toxicity. DVT prophylaxis and prophylaxis against GA bleed, that is stress ulcers, can be given as they are more prone for immobilization and sepsis. High fat and low carbohydrate diet containing gamma linolenic acid and eicosapentaenoic acid has been shown to improve oxygenation. Thank you, sir.
Welcome. Good. Nice. So yesterday she presented. At that time, I think the audio was also clear.
Yes, sir.
One or two more points in the pathophysiology is you have to mention that lack of uniformity of the disease process in the lung is a very pathognomonic feature of ARDS. One
Okay,
part of the lung may be very severely affected and another part may be not so severely affected. So there is no uniform involvement like in pneumonia or in other lung pathologies. And the second one is the surfactant production is also affected. And that protein and other things which are exuding out of the capillary into the alveolar fluid, alveolar side, causing the edema-like picture, is the reason for the prevention of oxygen transport from alveoli into the bloodstream.
Okay, sir.
Because of this hypoxia, that is the lack of oxygen in the alveolar side, causes a reactive hypoxic pulmonary vasoconstrictor reflex, which in the long term causes pulmonary hypertension and right heart failure also. That is also part of the pathology that has to be included.
Okay, sir.
And as I told yesterday, we have to talk a little about the earlier criteria by which ARDS was defined, where the importance was given to the absence of cardiac failure or the elevated PCWP, pulmonary capillary wedge pressure. Then the recent modified Berlin criteria, where now they are trying to make it easier for hospitals with lesser resources, where you cannot afford to do blood gas every time and go for CT scan or X-rays again and again to assess the involvement. They have modified that by taking the SpO2 FiO2 ratio and the bedside ultrasound to find out the opacities or infiltrates in the lung is also being utilized in a very extensive way. So these are the things that have to be included. So I'll just go to share my screen.